Omaha Mom Talks, proudly sponsored by Day Ventures Swim School, where giggles and goggles unite. Hey everyone, welcome back to Omaha Mom Talks. I'm your host, Jessie Gutierrez. I'm a wife, mama of two, and a therapist, bringing you into some honest conversations about some of my favorite topics: motherhood, mental health, and healing. Today's episode is one that I'm really looking forward to. We're diving into something that deserves way more space in the motherhood chat, and that is mental health during pregnancy and postpartum. Whether you're in the thick of supporting somebody who's in postpartum or it is you yourself, I hope this episode makes you feel seen and a little less alone. Today's guest is Anne Hofer. She is a local Omaha mom, a psychiatric nurse practitioner, certified in perinatal mental health, who specializes in reproductive psychiatry. She is the founder of Her Story and Our Story, which is a clinic devoted to walking with individuals through every season of their mental health journey. Anne brings compassion, expertise, and so much validation to this conversation. I think you're going to walk away feeling a little more informed, a little more empowered, and definitely less alone. So grab your coffee, take us on a walk with you, and let's get into it. All right, Anne, thank you so much for being here today.
Thank you so much for having me.
Yeah, I'm super excited to connect with you and chat more about medications and perinatal mental health.
Awesome.
Before we jump into that chat, just share with our listeners a little bit about you and what your life looks like these days.
Sure, yeah. Well, I have been married for 20 years as of last week to my husband. He's fantastic, so shout out to him. I have two daughters, a 15-year-old and a 12-year-old, so we're going into 7th grade and sophomore year.
Wow.
So that seems wild.
Yeah.
The older one can literally drive a car, which blows my mind. Yes, frightening, absolutely. I work my job. I own my business. I enjoy hot exercise, I guess. That's a new thing for me.
Like hot works?
Yes.
Okay, that's your
new... it's insane. Like the actual thought of it is like bonkers, but I absolutely love it. I think it's the most fantastic. So I do that. I enjoy working out just in general. I run for fun, which some people say is kind of crazy. I'm about to agree with them, but that, so that's that. But otherwise, we're busy with my youngest does competitive cheerleading, so that's like a year-round exciting adventure. My oldest is in one act and speech and wrestling. She just got back from Europe, so that was fantastic.
Oh, wow.
Yeah, it's a real good experience.
Brave. Yeah, really cool. So your family's always busy, always on the move.
On the move.
Not a lot of sitting.
Yep.
Well, share with us a little bit about your work that you do, kind of your credentials, and how you landed into psychiatric care.
Sure, yeah. So I have been a registered nurse since 2008. I went on and continued my education, and I got my my APRN, or my advanced practice nurse, registered nurse, in 2018. And so I've been doing some form of reproductive psychiatry since that time. As an APRN, I can prescribe medications. I can do therapy with patients. So that is, pretty much what I do on a daily basis, mostly the medication prescription, just because that's such a needed service.
Mm-hmm, mm-hmm. And tell us a little bit about Her Story and founding your business and what kind of services you all offer.
Yeah, absolutely. So Her Story is kind of my baby. Mm-hmm. So the reason that I got into reproductive psychiatry in the first place was my own experience with childbirth and postpartum experiences with mood issues. And after I had my first daughter, I was told some things that ended up not being actually factually accurate. And so I started doing some research on my own and figured out that even way back in 2009, the things that I was being told were not accurate in regards to medications and things like that. And so it became my goal to give women the best, most accurate, most factually accurate information in regards to medications and allow them to make their own choices. And so her story was born. So we specialize in taking care of women throughout the reproductive lifespan. So we start seeing people at around 12 or so, and then we'll see you all the way through till the end. Yeah. And a majority of our patients are women of childbearing age. So we do a lot of education, a lot of information in regards to medication, because I would say that we do very much bring in people who are already pregnant, but a lot of it is our pre-existing patients that go, surprise, I'm pregnant. Mm-hmm. So just a lot of education and things like that.
Yeah. And we're going to get more into some of that education because that's such a valuable piece. And even in, that was 2009, but here we are and we're still getting a lot of uninformed
absolutely
information out there. So, and at her story, I just want to kind of also mention you also have services for men as well. Is that correct?
So I actually own two businesses. Okay. So I have Her Story, which is specific to women. And then I have Our Story. So Our Story is more of a general psychiatry clinic. I have a nurse practitioner who works out of Our Story, and then I have two therapists. One of the therapists does have some training with perinatal issues with men. Uh-huh. So we do have that service available to our patients as well and their family. Great.
Just for, if there's providers or people who are looking for services to keep that in mind too with Our Story. Well, I'm super excited to jump into our chat about perinatal mental health, maternal mental health. We hear all the words that you kind of fall under the same umbrella. How do you think that this chat about maternal mental health has grown or changed just even from when you had your babies?
Oh, absolutely. So, the conversation has very much changed over the course of, let's just say, the last 25 years or so. So when the medications came out, probably close to 50 to 70 years ago, a lot of the focus was on, do these medications cause birth defects, which is a fantastic thing to study, right? Yeah. So a lot of our research was put into what do these medications do to a fetus? Mm-hmm. So, and that lasted us up until probably the early 2000s, at which point we had a decent amount of research to indicate that these medications are relatively safe in pregnancy. So the focus actually changed at that point to looking at what happens to mom, what happens to the pregnancy if we don't treat mental health issues. Right. And so I think that pivot was huge for the work that I'm doing today, because what we found out is that things aren't great. We don't want mom to be white knuckling it through mm-hmm. pregnancy or, the postpartum time. And so I think that, and now we have, close to 25 years of research that supports the fact that mom needs to be stable in order to continue a healthy pregnancy.
Yes, absolutely. And so just to kind of break it down even further, are there mental health medications that are safe for mom and baby during pregnancy? And what about during breastfeeding?
Yeah. So right now, there are actually very few medications that are fully contraindicated in pregnancy or breastfeeding. Those medications I tend just not to use because of the fact that my patients are they are of childbearing age, and mm-hmm. It's safer to not. So as far as medications are concerned, we actually have more evidence for the safety of SSRI antidepressants in pregnancy than there is evidence for the safety of antibiotics in pregnancy. Wow. So that's something where, people will take antibiotics every single day without batting an eye because that's what your doctor told you to take. But we actually have less research on safety there than we do on our SSRIs.
Yeah, I think that's huge. And I had no idea about that either. And in terms of, obviously there's also, I always use the term CYA, right? Mm-hmm. Cover your ass. And I feel like some general practitioner providers or even OBs, they if they haven't taken, enhanced classes or aren't up to date on reproductive medications or medications during that period of time, where can women, access that on their own? That maybe they're in a rural area and their, provider is like, no, medications are safe, or we have to wean you off all medications.
Right. And it's interesting because, like I said, we're here now, 25 years after sort of starting this research, where people are still very, very enmeshed with some narratives that aren't necessarily correct. And so I would recommend, Postpartum Support International has a lot of excellent resources as far as information is concerned. With the dawn of telehealth, we're able to reach all of these people, to be honest. So, it's something where if women are feeling dismissed by their provider, or they don't feel comfortable with whatever plan is put in place, look for somebody who does reproductive psychiatry and have a consultation. I have found that obstetricians are more than happy to turn over the care of the medications to me, as there is some liability with it. So that's their kind of CYA, but all in all, it ends up being a good experience for the patient because they're getting evidence-based care. Right.
And I always tell folks, start your care wherever you feel comfortable or wherever the earliest entry point is. So if you're seeing your OB or your primary care, and you can start there and then get maybe a referral to an APRN.
Yes, absolutely. And that is certainly, and primary care and obstetrics, they'll take care of the people that they can. And I think that that's really important too, because that helps to lighten our load as well.
Yeah.
So yes, start with somebody that you feel comfortable with, but if the recommendations aren't necessarily meeting the evidence, I think at that point you certainly have it within your right to look elsewhere as well.
Absolutely. And I will just say for those listening, I am somebody who, so I experienced a lot of postpartum anxiety with my firstborn, and knowing what I knew for my second pregnancy, I went ahead and chatted with my OB during that pregnancy and said, I'd really like to get on something at this point, so that way the medications are well within my system and good and working for when I need them. And she was lovely and said, I think that's a great idea, right? And so we started on sertraline. And because I know what I know, I was this is the dose that I'm kind of thinking. And I do find sometimes in my own patients that this is a general statement, so this isn't everyone, but a lot of times I'm seeing, because we want to keep patients on the lowest dose that's effective.
Correct. Yep.
But a lot of my patients I'm seeing are on a really low, maybe non-therapeutic dose.
Right.
And I'm not a prescriber, but I'm seeing this often, and I'm seeing my patients oftentimes once a week. And so how can folks kind of navigate that if they're seeing, to me, I'm like, that's when we benefit from a specialist like yourself.
Yeah, so that's actually, so that kind of was the belief back now, 20 some years ago, was that we wanted to be on the lowest dose possible. Just sort of white knuckling it, but, do the best that you can with the least amount of medication. So the way that the conversation has changed has affected what we're recommending at this point. So essentially, when we're talking about pregnancy, we talk about limiting exposures, okay? So exposures are going to be maternal illness. It's going to be medications. Each medication is going to be a unique exposure. So ultimately, what we want to do is we want to limit exposures, okay? So what that doesn't look like is taking 25 milligrams of Zoloft and then having panic attacks 3 times a week, but, and thinking that you're doing what's best for yourself or the baby. So I recommend for my patients to be using the lowest effective dosage, right? So, and the other thing about that is, and this is something that people I don't think know at all, is that there is no dose effect of medication in pregnancy. So what that means is that 25 milligrams of Zoloft is no better than 200 milligrams of Zoloft. So when we're looking at that, we want to use the dose that's going to be most effective, because that allows us to not expose the baby to both maternal illness and medication. So that's where we get into trouble, is when we're exposing baby to both.
Right. And when I hear you talk about exposing baby to maternal illness, so for those that are listening, when you are pregnant, when mom is pregnant and has maybe PTSD symptoms or high anxiety or depression, tell us what some of those negative things that baby are receiving through utero.
Yeah. So in those situations, what happens is we have a stress hormone called cortisol. Everyone's pretty familiar with it. It's kind of having a moment right now. But it's a real thing. So we have cortisol that's released when we are stressed, anxious. It's released also in depression. Obviously, if there's any type of panic, flashbacks, things like that, will release cortisol. And so what happens is that your placenta can filter out part of that cortisol, because they've done studies on women who have been through like natural disasters or like a car accident or loss of a loved one during a pregnancy. And so in those situations, the placenta can really neutralize a lot of that cortisol, because it's sort of a one-time assault. But when we're having constant assaults on that placenta by cortisol, that's when we start seeing problems. And what happens is then more cortisol goes to baby. Baby is actually born with a higher baseline cortisol level, which is not what we want. But the good news is that all of the evidence indicates that if mom is treated, if mom is not symptomatic, baby's cortisol generally is normal. Another risk is just that we can have some issues with preeclampsia and things like that. Preterm labor is something that can happen frequently with somebody who has active symptoms and is not medicated throughout that time.
Okay, thank you for kind of giving us some of those, because I do think that, as a person that knows this, but also as a mom, like I also weighed the pros and the cons when I was pregnant of like exposing baby to this medication. And then I had to do my own reality check of like, but Jessie, you also know what exposure baby is getting to your uncontrolled anxiety. And it's such a personal choice. And I never want anyone to think that it's an easy black and white decision.
Right. Well, and I think too is opening that conversation in like a non-judgmental way, right? So I think most of my patients respond extremely well to facts and evidence and the recommendations by the American College of Obstetrics and Gynecology. I mean, back in 2011, they were saying, listen, mom needs to be well in order for baby to be well. So it's one of those things that we have the evidence to support. And I think when you open that conversation without judgment, without any sort of expectations, I think people do respond well to that. And something that I always do is I'm going to give my patients all of the information. I'm going to let them ask every single question they have. I'm going to have them bring their husband in if he has questions. And then we're going to make decision as a team, right? It's not going to be me telling somebody that they need a medication. It's going to be us deciding together that this is probably our best option.
Yes. And I want to kind of take a moment and pause and break a little bit of that down. So as a mental health therapist, so sometimes women come to me in pregnancy, or I have women who also like are not trying to get pregnant and then become pregnant, or people who've had their babies, whatever, right? I see women of all ages as well. So when I have somebody who comes in specifically in pregnancy or postpartum, we'll start there, and they are experiencing postpartum distress, for lack of a better term, just to kind of generalize it, I always start with my intake discussing some of the treatment options, and I include medication, and I assess essentially where they are at with their comfortability. And people are usually pretty open with telling me like I'm anti-medication, or oftentimes I'll hear my family has a history of addiction, so I'm really, really nervous about any type of psychotropic medications and the risk of addiction. And some people are on the fence, or some people are like, I'm open to whatever you recommend. So we just kind of assess that in the beginning. Also, I am for all of my new patients, I'm doing mental health screeners with them and using that as an objective tool that is giving me a picture of what their symptoms are and the severity. And so if somebody's coming in with like really, really mild symptoms, we're going to try therapy and we're going to try, managing their sleep, reducing their stress level, working with coping skills. But if somebody is coming in with a really high symptomology, I want them to feel better quicker. And most people want to feel better quicker. And we know, and the research shows that the way you feel better quicker is a combination of medication and therapy.
Absolutely.
And so these are just tools, and no one has to do, therapy or medication or any of the things that we recommend, but I'm going to present it to them. Now, if I have a patient who is really reluctant about meds, I'm going to respect that, right? And we're going to continue with therapy interventions. And then if we ever get to a place where I feel like, especially if I see symptoms are worsening or becoming more severe, then I'm going to very gently bring up that conversation again as an option. But it's always their choice, right? And then part of my practice is I'm going to provide them with some really reliable, trustworthy referrals like you and the folks at Her Story that I know understand perinatal mental health and are going to take really, really good care of my patients. So I guess I never did mention Anne and I know each other because we support one another on a perinatal consultation team where we have this wonderful group of providers from different backgrounds, such as medical social work, doulas, mental health therapists, and reproductive medication providers. And so we refer patients a lot with each other, which is really just beautiful because I feel like they're in good hands, right? I care about these folks. I want them to be taken care of. And so a lot of times when I refer folks to you, I will maybe give you a heads up of like, this person is reluctant on meds. And so let's just start with you assessing them, you deciding if you think medications could be beneficial, and then having a chat with that person. And they don't have to make a decision when they walk away. Chat through kind of like, once I get them to you, what that may look like for an individual.
Yeah. And I mean, and to kind of speak to what you just said, I think that your role in sort of the medication journey is really invaluable in so many ways, because I think therapists are such a trusted person for people. They see them every single week or every other week, where medication providers, we're not seeing them as often. So a lot of times therapists will have a lot of sway as far as like opening that conversation up. If I get patients, and this is anybody who walks in my door, I mean, we will do a full assessment, right? So we'll go through, we use all the same kind of screening tools to determine, do we have a symptom load that requires medication even, right? And then we would proceed then with just options. And generally speaking, like I'm going to give patients like several options. My first option is always do nothing and hope for the best. So it is an option. And so, but then I will give them, I'll have, 2 different medications or maybe 3 different options that I'm thinking of and kind of walk through the benefits and drawbacks of each one. If patients want to leave and think about it, they want to talk to a spouse, a friend, somebody in the medical field, I'm entirely open to that. So as soon as you walk through my door, you have access to me. And if you walk out my door and 10 minutes later, you're like, I want to take that med, you email me and I go, okay, let's do it. Yeah.
Yeah. And for folks that, so I hear from a lot of my patients, but also just in general, is that people have this feeling of like needing medication means that they're weak or something's wrong with them or they're a failure. And what do you say to those folks?
So it's interesting. So how I typically bring it to people like that is I try to compare it to a physical illness, right? Because, and so we talk about like type 1 diabetes, right? You didn't do anything to cause this. It's not your fault, but it's your responsibility, correct? Right? So we talk about the fact that somebody who has diabetes and checks their blood sugar and takes their medications, takes their insulin, watches their diet, diabetes is something they manage. It's not who they are, right? But that same diabetic, so if they are like eating whatever they want, they're not checking their blood sugar, they're not taking their insulin, they're going to have so many consequences from that, right? So they're going to have infections, they're going to have toes amputated, they're just going to feel super unwell, right? So the same is true for mental health, right? And it doesn't matter what mental health we're talking about, right? Bipolar disorder, schizophrenia, depression, anxiety, all of it is manageable, right? So when we talk about medications, a lot of times people feel like mental health medications are something that's like more voluntary. I'm doing air quotes here, voluntary. But if you treat your depression is something you manage. It's not who you are. It's not making it difficult to get out of bed. It's not making you call into work. It's not, dictating your day to day. So I don't think it's a form of weakness. Obviously, This is what I do every day. Right. But I think when you compare it to something else like that, people can more easily see that connection where, like, I didn't ask for depression or anxiety, but here I have it. It's not my fault. It's my responsibility, though, to take care of myself and treat it. So,
right. Yeah, I think that's a great comparison with physical health. The other thing that I see in that same realm that I'll just say, is frustrating to me, and I see it a lot on social media because I follow a lot of content creators and mom influencers, is that a lot of folks that I follow will take any supplement before they'll try medicine, and they'll say, like, this is my last straw or my last try before I resort to that. And that narrative does frustrate me. And I will also add, I love supplements. I take supplements.
Yep.
I just worry of like the idea of that is somehow safer when it's not FDA approved and may not have the same research backing it. What are your thoughts?
Yeah, no, opinions? That's a really good question, because I do find that people really do try to, they try to manage in the way that they know how. And so sometimes that's supplements, sometimes it's alcohol, sometimes, and so people do manage in the way that they think they need to. But you're totally correct in the fact that we don't have these longitudinal studies on their use. Like if we're talking about pregnancy or even just use in general, sometimes if it's kind of a newer thing. So I think where people believe that these are like quote unquote safe, we don't necessarily have the evidence to support that. And so I would say, if it was me, right, and especially during a pregnancy, right, I would definitely want to have something that was supported by evidence.
Yes, yeah. Absolutely. Another thing that I hear a lot from my perinatal clients is they don't want to be on medications long term. They don't want to rely on it forever. So tell us, is this always a long-term thing, or can it be a temporary support?
Yeah. So this is something that I also deal with most days of the week. The way that I kind of explain it to patients is I generally tell them, let's not look at the finish line before we've crossed the start line, because we don't know what we don't know. Okay. So these people are, coming to me and they don't know what life is like without depression or anxiety or, whatever it is that they're struggling with. And so once I get you feeling better, your perspective is much, much different, right? So what best practice dictates right now is that if somebody is having a mental health crisis, an issue of sorts, that we treat you, we keep you well for a year, and then we reevaluate. Okay. So, honestly, it can be temporary. It can be a long-term thing. It really depends on the person. And a year from now, you can see things much clearer than you did on day one. So that's kind of what I reinforce to my patients, is just that, this is always going to be your choice. And the other part about that is if my patients come to me and they're like, hey, I think I want to get off my medications, right? I will help them do that if they're very insistent on doing so, because it is more important that we maintain our relationship and that patient feels comfortable with coming back if they're like, yeah, that didn't work so well, right? And so that's a really important part of this whole journey. And I've had patients successfully go off medications after that year and do really well. I've had them come back after 3 years and be like, hey, I'm struggling. And that's fine too, right? That's what we're here for,
What can you say about just because again, I'm working alongside and supporting women and finding the right medication
Sure.
and just kind of acknowledging that it is a process and it's not always like I give you this med and I can guarantee it's going to work for you.
Right. So, I think probably professionally, that's one of my biggest frustrations, right? Is that it is so much of a trial and error process. Generally speaking, when we start a medication, we're going to start something that's cost effective, that's pretty efficient. We're going to try to get something that matches your symptoms so that we can try to get everything taken care of with one pill, as opposed to multiple different pills.
What are your thoughts about like genetic testing for psychotropic meds? Is it useful? Is it a waste of money? What are your thoughts?
So I do it for my patients if it's something that they want. It's something so genetic testing came out right around the time I was going through my master's program. So like right around 2012, 15-ish, somewhere in there.
Okay.
And it was like a bombshell for us because right now we don't have any objective measures to measure like mental health, right? You go to the doctor and your throat is sore, they swab your throat and you've got strep, right?
Right.
That's easy, right? And so this looked very promising to us. And so it's something that I will say that it has evolved over the time that it's been around. I will do it if patients want me to do it, but I will say there are limitations. So for instance, I have had patients where we've done the genetic testing because they've been on just so many different medications. Yeah. And it comes back that 10 of the 12 medications that they've taken should have been effective based on their genetics.
Wow.
Yeah. And so you're like, okay, well, that wasn't helpful,
yeah.
right? Huge bummer. There are some clinically utilizable information though within the genetic testing. So genetic testing will tell you if you're an ultra rapid metabolizer. So if you're going to run through medication quicker, might need a higher dose. If you're an ultra slow metabolizer, you'll need a lower dose, or you might have more side effects to a medication. So that information is clinically utilizable, but I will say that because of the cost of this testing and the fact that some insurances cover it, some don't, I would say, the trial and error process, while frustrating, is sort of what we're left with, you know, for the most part. Yeah.
One of the things I try and help moms with is if a medication isn't working for you, a lot of times because especially if it's like depression and anxiety that they are dealing with, their negative belief is I'm so messed up that even meds don't work for me. And so trying to encourage them that maybe it's a dose issue, maybe this medication isn't the best fit for you. Sure. What do you say to those folks?
Absolutely. So medication. So I would say that most of the people that come to me and say my medication isn't working are not on the max dose of medication, right? And so what I see a lot is that when people are taken care of in primary care or obstetrics, like if they put them on a medication, the minute that they're like, well, it doesn't feel like it's working, instead of like escalating the dose, they'll just take them off and try something else. So we get all these trials of medication that make people feel like, oh my gosh, I've tried everything, but they've tried everything at like subtherapeutic doses. So I explain to my patients, like, if you're going to be taking a medication, we ought to take it at least at a dose that can help. And so I think that's the difference between psychiatry and just like general practice is that we're going to run that medication up unless you're having side effects, in which case then we will try something new.
Yes. So hearing you say that is if you're having negative or early side effects to a medication, then that's worth a chat of exploring a new med. But if it's just not working and to the benefit that you want it to, but there aren't any negative side effects, maybe we can just chat about a dose.
Correct.
Change.
And so the other frustrating part you kind of touched on is the early side effects. So what's frustrating about medication management in this setting is that all of our medications take 4 to 6 weeks to become effective. So we're really running up on we're already behind the 8 ball, if you will. So I think it's really important to encourage patients to kind of hang tight too, which is a lot of what I do as well. Because a lot of times you're going to feel side effects before you feel benefit, right? So for those first 10 to 14 days on a medication, very likely to have side effects that will actually probably improve.
Okay.
And but but you're still probably not going to get benefit for at least another like 2 to 4 weeks after that. Mm-hmm. So, that's a frustrating part of what we do as well.
Yeah.
So,
yeah. Hey friends, this is Jessie. Before we dive into today's episode, I want to give a big thank you to our season 2 sponsor, Diventures Swim School. My kids started weekly swim lessons at Diventures back in February 2025, and honestly, I've been blown away by the growth that I've seen in just a few months. As a water-loving family, water safety is super important to us, and Diventures has given me such peace of mind as a parent. I'm going to share with you just a few of the things that I love the most about Diventures. They offer classes for all ages and stages, starting as young as 2 months all the way up to adults. They have small class sizes with just 4 kids max to 1 adult, so they really do get a lot of that one-on-one support. They have a heated pool, so no battles over getting into cold water. They have flexible class times, which allow for rescheduling when life gets busy or you're going to be out of town. And of course, expert instructors, all certified and truly just amazing with kids. If swim lessons has been on your list, this is your sign. Head on over to diventures.com and find a class that's right for your family. In terms of PMADs, perinatal mood and anxiety disorders, is there a best medication, or talk to us a little bit about some of these newer meds that are being released as well and what some of maybe the positives and barriers are?
Yeah. So, as far as a best medication, the best medication is the medication that makes mom better, right? So, that's going to be what it is. Okay. So when I first started training in perinatal psychiatry, the idea, Paxil is a really hot topic, right? In like pregnancy, because Paxil has a specific side effect or a specific effect in the fetus that increases your chances of having this genetic anomaly from 1 in 1,000 to 2 in 1,000, which is not a statistically significant increase. However, it is enough to make people go, yeah, I don't want to chance that. Yeah, I don't want to chance that. But the first thing that was told to me is if mom is well on Paxil and she's been on other things and they haven't worked, then Paxil is what you're going with. And that is something that is very important, because it's not any specific medication. Certainly I know what the OBs will want me to prescribe or what they would first prescribe, and that's what I'm going to go with always in pregnancy if I have that as an option. But ultimately it's whatever gets someone well, and especially if they've had a difficult time getting there, it's something that we would just go with as like, that's what we're going to do. So.
And then chat with us a little bit about some of the newer medications that we're seeing specific to perinatal pregnancy and postpartum.
The medications that we're seeing right now that are coming through are medications that, frankly, I don't use just because of the fact that they're incredibly expensive right now. At first, these medications were available only by IV infusion, and so that was a really big stumbling block to implementing those as an option. We do have oral forms of this new medication that can be used. The current recommendation, though, is that you do pump and dump for the 14 days that you're on that medication.
And what's the name of that med?
Zuranolone.
Okay.
Yep. So, it is, that can be really frustrating. And the other recommendation that I find that's not actually being consistently implemented with that is you are supposed to be on an antidepressant medication concurrently with that medication. Okay. So it's a short-term medication that I think it's either 14 or 21 days. But you have to be on another medication concurrently. And so, like I said, the availability of those medications are difficult to get.
The accessibility.
Yes, the accessibility for most people. Yeah. And the problem, too, that I see is that if it is something that perhaps could be accessible, it's going to require a prior authorization, which could take days to weeks, depending on your insurance company. And a lot of people just don't have that long to wait, So I think there are some some risks and benefits that we have to kind of weigh out with the new medications. I think with more consistent use, we'll see a lot more research, a lot more evidence coming forth, and hopefully a little bit better reimbursement through insurance and things like that.
Yeah, absolutely. Well, let's chat a little bit about a mom is feeling kind of unsure if she needs support or needs help with her mental health during pregnancy or postpartum. How can partners, friends, or family be helpful in getting them to the support that they deserve?
So my recommendation unequivocally is non-judgmental support, right? What I try to do is normalize these experiences for women. And so what I do with all of my pregnant women is I do what's called I do preconception counseling as well, but I do pre-delivery counseling. And in those times, we talk about all of the things that might pop up after pregnancy, right? And we discuss the fact that it's normal to have anxious, intrusive thoughts, right? But what do those look like versus like a postpartum psychosis? How do we know the difference? And so I think for women, it's normalizing this experience. Like I think what we're doing right now, sitting here and talking about this and bringing light to the fact that this is a very common phenomenon is doing good in this world. Because I think as women, we tend to gatekeep that because we think, well, I have this baby, someone else would be so happy to have it. Why am I sad? And so you feel not only your own judgment, but you feel the judgment of society upon you. And so I just think as a mental health community and even OBs, like help us out here, but just normalizing that like breastfeeding is hard.
So hard.
Right? Not sleeping is hard, yes. Right? That it's normal to have some level of symptoms after the birth of a child, but what does that look like versus pathologic issues, right? So we go through all of that kind of stuff. And so I think the normalization and just the non-judgmental approach is the best way to go about it. And finding a provider that's similar to that, I think is also important.
Yes. And what do you recommend that folks look for in finding a medication provider? If they are listening and they're maybe not in our area, like what should they be looking for if they're pregnant or postpartum?
I would definitely recommend that they find somebody who is perinatal mental health certified. So that is essentially the highest level of education we have available to us in this perinatal or reproductive psychiatry realm. It means that they've taken additional training in order to understand and safely prescribe medications to pregnant and postpartum women. So I would definitely recommend that. Postpartum Support International has an entire directory of everybody who is perinatal mental health certified in your area. And so that would be a really good resource to start with, just because you're starting with somebody who understands what's going on, I think.
I think that's important as well. And just kind of thinking of, I'm sure there's so many similarities, but what are some of just like your favorite parts of your job or moments that you like keep you going? Because there's so many hard things, right? Yep. But what are some of those really beautiful moments that you love?
I think the thing that I enjoy the most is when I get a woman into my care following a first pregnancy, and so they're in their postpartum period, they're having depression, anxiety, mental health symptoms, we treat them, and then they go on to have a second pregnancy, and almost unequivocally, they come back and say, this is so different. I didn't realize that I could be happy after I had a baby, or I didn't know that I didn't have to struggle through pregnancy. So I would say that that's probably the one thing that keeps me going, because like I said, my goal is to not allow women to go through the same things that I went through. Mm-hmm. And I think that's what drives me every day. And that's what drove me to found my business, and it pretty much runs my everyday.
Yeah, I love those moments too. And sometimes it's even women, like you mentioned, that are in that second pregnancy, and they also are like, wow, I didn't even know how bad it was before, yes, because this is such a totally different experience, and I'm present, and I'm, in it. And that is just such a beautiful
It's fantastic. It is. It's wonderful to see. And I mean, yeah, it's what keeps us going, I guess,
Yeah, absolutely. Well, Anne, thank you so much for connecting with me today. I really appreciate your value and your wisdom. Where can folks learn more about you and her story?
Absolutely. So we have a website. It's www.herstoryomaha.com. And that is where you can find all of the information about my different providers, as well as myself. We also have a website for Our Story. So if we're looking for dads and help for them, it is www.ourstoryomaha.com.
Wonderful. Well, I will also add that when I send folks to your website, I give them a disclaimer and I tell them she looks like a preschool teacher, but she's not.
Absolutely not.
Because you look so angelic on your website, and I'm like, no, she's direct, she's smart, she's going to give you factual, evidence-based information and support you to make an informed decision, but she's not that sweet preschool teacher that her profile looks like.
Yes. So we're updating the profile photos here soon. No, I don't think everybody's ever described me as a preschool teacher. No, I mean, I might swear every once in a while.
She swears, she has tattoos.
Yeah, I got tattoos. I might be in ripped jeans. I mean, you just never know. But yeah, definitely. Yeah, it's yeah. No.
And everybody that I tell that, they're like, oh, you're right.
Totally right. I get it.
It cracks me up. Well, thank you again so much. Thank you for sharing your wisdom and all that you do for the women that you support.
I appreciate being given the opportunity to do so. Yeah, thank you.
Absolutely. All right. Thank you so much to everyone listening to Omaha Mom Talks today. If you found this episode helpful, please share it with another mama that could use some extra support right now. And we'll see you next time on Omaha Mom Talks. Omaha Mom Talks. Real moms, authentic conversations, no filter needed.